Hello, Aidan. Welcome back. Hope you can hear me.
Yes, I'm here.
Thank you for coming back and joining in.
Yeah, it's a pleasure. I had some problems, absences, funeral, but now it's everything is okay. It's actually today the Swiss national holiday,
Oh,
1st of August. But I'm not very patriotic still. Thank you for all your preparations. Looking forward. Bye-bye.
Bye-bye.
Hello to all other Indian colleagues.
All right, Sridhar, if you're there, we can start. Yeah, I can see
Yes,
Sridhar there. Okay, right.
Yeah.
All right. Yeah. So good evening, everyone. Once again, thank you for joining in our bi-weekly sessions. We have a very interesting and complex set of cases today. The chat is open, so please leave in your comments and suggestions for the cases. We'll be happy to answer them. Without further ado, I'll hand it over to Sridhar for his two sets of cases. Sridhar, over to you.
Good evening. So this first case is a 11-year-old male child, second born to non-consanguineous parents. He presented with following concerns. So this is his fourth pediatric neurologist, I must say. So it has been a long journey for the parents as well. So the first concern is delay in attainment of age-appropriate milestones, motor more than socio-cognitive and language delay, abnormal faces, poor gain in height as compared to peer group, progressive gait difficulty, and lower limb deformity. So he has been labeled as someone labeled him as cerebral palsy, another team labeled him as autism, and then he underwent a stem cell transplant at a famous center with a label of CP and autism spectrum disorder in Mumbai. Basic workup, hemogram, thyroid function test, CPK, homocysteine, ammonia lactate, TMS, GTMS were normal. Had two prior imaging done, but only reports were available. They have reported it as dismyelination and supratentorial white matter, but no films were available. The parents are from UAE. Because of this low height, he was evaluated by pediatric endocrinologist here in Vadodara only, where clonidine stimulation test was done, and the peak GH was less than 6 nanogram per deciliter and was started on growth hormone injections. Other workup for growth hormone deficiency were normal. So this is a child with multi-system, multi-neuroaxial presentation. So it has an endocrine presentation with multiple neurological complaints, spastic ataxic phenotype. So they were only there for 2 days. So I only got I had previous some reports available and got the imaging done. So in the second child, we can see the faces of the child. He has triangular faces, some bilateral alternate divergence, squint, generalized wasting, and we can see the video in the next clicks. So you can see that classic Caesar gait with some in-toeing. In the second gait also, it shows a broad-based stance and classical scissoring gait with spastic ataxic phenotype. He's an 11-year-old. You can notice that the height is short. So all in all, we have a child with global delay, with spastic ataxic phenotype, with facial dysmorphism in neurology, with growth hormone deficiency in endocrinology. So it's a neuroendocrine presentation. I don't have previous imagings. We got a new set of imaging done just last week. So we can discuss the imaging and then discuss the differentials based on this presentation.
Yeah, thanks, Sridhar. So yeah, here we have the T2s and the flare axis sequences. What you can appreciate that there is a cerebral and cerebellar atrophy with this confluent white matter changes from the periventricular regions going up to the some areas of the subcortical regions of the bilateral cerebral hemispheres. On the T2 variant sequences in the deep brain nuclei, you can appreciate some hypointensities along the globus pallidi out there. We'll have a look at the SWA sequences if they correlate or not. But yeah, an extracorporeal dilatation of the lateral ventricles, you can appreciate that the x-axis spaces are also widened because of the parenchymal volume loss. And also cerebellar atrophy is demonstrated. On the flare sequences, you can appreciate the white matter changes, confluent in nature, almost symmetrical, going from the periventricular to the subcortical regions of the cerebral hemispheres on both sides. No focal lesions, no structural malformations. Yeah, these are the main findings. And if you look at the calvarium, it is also hypertrophied. So some calvaire hypertrophy also is demonstrated. On the diffuse sequences, do not appreciate any acute. These are some high signal change in the brainstem, but I think they are more T2 shine through than the real changes. But yeah, nothing significantly stands out on the diffusion IDCs. On the GRE or SWA sequences, you can appreciate areas of blooming in the global spiral line. This is the substantia nigra, the red nucleus on both sides, almost symmetrical in nature. And then if you look at the midline SAD sequence, you can appreciate there is a thinning of the corpus callosum. You have reduction in the volume of the posterior fossa structures, especially the midbrain and also the cerebellum. T2 screening of this the spinal cord was done. We don't have axial sequences. I don't see any volume loss of the spinal cord. There is some faint hyperintensity of along the entire length. I'm not sure if this is real or artifactual. We don't have axial sequences, but in terms of volume, it is preserved.
Yeah, the radiologist reported here, he told a large FOV one. Actually, artificial.
Okay, all right. Then yeah, see that you can take over. We are dealing with neurodegenerative disorder, probably with iron accumulation in the deep brain nuclei and brainstem structures. I think these are the points kept by Sridhar. So Sridhar, you can maybe just highlight the points and the genetic reports.
Yeah, so basically, based on history and clinical examination and investigations, this iron accumulation in basal ganglia and with neuroendocrine phenotype, the first differential clinical radiological was NBIS spectrum only. The two NBIS which I know with white matter abnormalities are fatty acid hydroxylase deficiency and Woodhouse-Sakati syndrome, with endocrinopathy being more common in Woodhouse-Sakati syndrome. Other differentials were aceruloplasminemia and chromosomal neuroendocrinopathies, but they were not that significant. Another thing was a GM gangliosidosis, but they were more of dystonia rather than spastic ataxic phenotype. This genetic test was done elsewhere, which showed genes, which showed VUS in HERC2, ZC4H2, and SCHS gene, but these were not matching the phenotype clinically as well as radiologically. So we have sent a repeat whole exome plus mitochondrial genome to another lab, and the report is still awaited. These parents usually, it was consulted to me by an orthopedic physician, a surgeon, because they wanted to do this soft tissue release for the child. But as the child has a progressive course, I have counsel against doing the thing. We don't have an exact diagnosis yet, and I want to discuss if there are any other possibilities based on this history and examination. Thank you.
Yeah, as Sridhar has mentioned, yeah, the radiological differentials with the white matter abnormalities, as you can see, Fan, Woodhouse, Sakati, and maybe aceruloplasminemia. I don't think the child clinically fits cocaine syndrome, though they can be associated with white matter changes, cerebral atrophy, no cataract or any orbital or hearing loss, no? Sridhar?
No hearing loss,
Yeah,
no cataract.
Yeah. Storage disorder also, I thought, but yeah, it doesn't quite fit into any of the storage. Maybe fucosidosis, but again,
yeah, that's what he does not have any angiokeratomas or any pore spaces or something like that.
Yeah.
So the first differential which I thought was Woodhouse-Sakati only, but because of these faces, I wanted to know if anyone has had seen such face and such phenotype previously, which might help in better diagnosis. It's just for a discussion part only. We have sent the exome and the final answers may be lying in there only.
Yeah. All right. Case is open.
No experience, and I can't say something about this face. Just two simple questions or remarks. First, I think the term dysmyelination, as mentioned in the first slide, is confusing, and of course you have taken this from a report. It's not clearly defined. And then I'm interested whether this so-called famous center is a serious center offering stem cell transplantation in cerebral palsy, so-called, or is it maybe a business center?
It's a center in Mumbai.
You understand my question?
The second part I did not get that much.
I think I got it.
My suspicion or my claim is that stem cell transplantation in such a situation is useless. It's just
yes,
costly.
that's what it is useless. That's what It is useless. That's what we say usually. That this patient is. I am the fourth doctor, well, pediatric neurology wise. They have been to multiple places. None of the pediatric neurologists have suggested for stem cell transplant, but parents just to go to do everything they have done this. But this is not recommended by any of our societies, and it is just a useless thing. And he is not either a CP or autism. That's why I highlighted. But this is a useless treatment. It should not be given. I did not write the center's name. I know it, but we all know that it should not be done, and that's why I highlighted that. That is another. At least even if I don't get the diagnosis, the house should know that such treatments like stem cell transplantation should not be done in these disorders. There are some fixed indications for stem cell transplant, and it should be done only for those indications.
Okay, thanks.
But this phases and with this history, if anyone has any other thoughts, I would like to know.
Khalid says Woodhouse Sakati, yeah, I think radiologically a possible differential, yeah. David comments on the other topic, but yeah.
The only thing is, did you see the pituitary cuts? In Woodhouse Sakati, what I reviewed is they have a small pituitary, but I did not find a small pituitary in this thing. That's why I was not sure about Woodhouse Sakati that much. Otherwise, the other scan features do classically match with Woodhouse Sakati syndrome. If you see the AJNR article, they have given this thing, but the only thing is small pituitary is not there. Maybe because there's some growth hormone. Yeah.
No,
because,
we have to measure it.
Yeah. Measure it. Okay, sure.
For 11-year-old, I think the anterior gland appears to be slightly yellow. Half of it is occupied the posterior. If you measure the volume, I think it will be low.
Low. Okay.
Yeah, it should be low. Yeah. But we'll have to.
So basically,
volume. Yeah.
So what happened? The previous exome was done. They only mentioned that child with CP and autism. That's why these genes were given. Now I've given a detailed history with a detailed phenotyping. Let's see. I hope that this time parents get an actual diagnosis and they stop running from center to center.
Any hematological abnormality?
No hematological abnormality.
Narrow.
Could I ask a question?
No.
Nihaal?
Yeah.
What is the clavum like?
Clavum is fine. It is not INAD. If that is.
I understand that. Is it more prominent than normal, or you think so?
No, because there is volume loss dorsally of the brainstem. It appears to be prominent, but it is not.
No, but that's the reason why clavum seems hypertrophic even in INAD. The medullary areas are a little thinned out, and that's why it looks more prominent.
But here, I wouldn't call it.
Also, atypical INAD also. I know the history in this patient, but the atypical INAD also comes with iron deposition and cerebral atrophy and stuff.
Yeah.
Yes, sir. But this is a spastic ataxic phenotype, and he has also facial dysmorphism and growth hormone deficiency.
But I was there because the atypical INAD comes with ataxia and autistic features and stuff like that.
Features.
But and that the iron deposition is much more prominent in the atypical variety, the one which comes later.
Later, yes. Agreed.
Okay.
So Caesar, we're thinking of NBI only. So once you have given the
once I get the diagnosis, I'll review the case and share it again. Fine.
Yeah. Okay.
Sure. Thank you.
All right.
So this is another case, just discharged 2 days prior. So this is a 6-year-old female child, second born to non-consanguineous parents, presented to pediatric casualty in active seizures, generalized tonic-clonic seizures they were, and following seizures, it was aborted with midazolam, and then she had respiratory failure. So child was intubated and mechanically ventilation. Post-intubation, her temperature was normal, but she had a tachycardia of 238 per minute. ECG was done, which was suggestive of paroxysmal supraventricular tachycardia. So it was aborted with a single dose of adenosine. And this was all in presence of an intensive care specialist. So She also had recurrent seizures. Subsequently, was loaded with levetiracetam followed by fosfenitoin. So this is on the first day, first 3-4 hours, where I was not even called. It was all happening when I was not there in the hospital. So once this 2 loadings were done, I was called in. There was history of mild fever associated with cough and cold since last 2 days. On examination, the child was sedated with preserved all-eye response, had generalized wasting, terminal neck rigidity, Brudzinski's leg sign, and mildly reduced dependent reflexes with bilateral plantars which are flexor. So, based on the history of 2 days of viral cough cold with seizures, some PSVT, a provisional diagnosis of acute viral encephalitis by pyogenic meningitis was kept, and the child was initiated on ceftriaxone, acyclovir, and dexamethasone. We'll discuss the investigation subsequent slide. However, the child was extubated after 48 hours, that is day 3 of admission, and DEXA was stopped after 8 doses, as we usually do in acute pyogenic meningitis. Next day, after stopping DEXA, child became paraplegic and had bladder retention. So basically, when I saw the child, when she was on ventilator, she was moving the lower limbs, at least 3/5. But after stopping dexamethasone, she became completely paraplegic with bladder retention. So DEXA was restarted. However, on restarting DEXA 1 day later, that is day 4th of admission, the child developed right eye ptosis, followed by left side ptosis on the same day, and bilateral complete external ophthalmoplegia with INO, which was worsening despite restarting dexamethasone. So this is bilateral paraplegia with neurogenic bowel and bladder, external ophthalmoplegia with INO. All these things started in the hospital. Is for not the presenting features, and there was worsening despite steroids. So fever subsided. First day itself, some mild fever. After that, there was no continuing fever. So fever had subsided. So these were the deficits arising inside the hospital. So then we proceeded with imaging. Yeah, I think. So this was the first imaging which was done on day 3 of admission. Day two of admission. Before she became paraplegic, this was the first thing which was done in day 2 of admission.
Okay, so we have 3 sets of scans with interval of, I think, within 2 weeks of time. So this is the axial flare sequences on top. The main changes are around the central regions. If you see the basal ganglia slightly hyperintense, but the external capsule and the claustrum is demonstrating the flare hyperintensities. The posterior thalamic nuclei also are demonstrating flare hyperintensities. Some anterior periventricular hyperintensities are there. Posterior fossa, I do not appreciate any significant findings. Midline sag, you can appreciate again the brainstem, cerebellum, and the corpus callosum appear to be normal. On the diffusion-weighted sequences, these changes do not demonstrate corresponding area of distributed diffusion, and no hypoxic changes or typical hypoxic-related changes as the child was intubated and extubated also previously. So no acute or changes on diffusion or diffusion restriction on these sequences. Contrast was given. I'm not sure if the optic nerves appear to be slightly inflammatory out there, especially the intracranial portion and the proximal orbital portion. There's diffuse attenuated appearance of the leptomeningeal aspects. Was the contrast dose appropriate, Sridhar? I'm not sure if you would be able to answer this question.
No, I am not idea. Sorry.
Yeah.
This was this was interpreted as a diffuse meningeal enhancement.
No, I would probably call it more of an excessive contrast dosage than diffuse meningeal enhancement.
Okay. Yeah, I think there was also flare contrast in this scan, or was not there.
I don't think in this scan. Maybe the follow-up scan.
Okay. Sure. So this was the scan on day 2, and on day So there was CSF done, which showed this. So this is, I think, protein is 679 and glucose is 45 with 60 cells were there. So the cells were predominantly lymphocytic. So there were raised cells and protein. So again, lymphocytic leukocytosis with raised protein, decreased sugar. We were treating it like a neuro infection. I would accept that I saw this scan, and because this CSF was there with me, I treated it like a leptomeningeal enhancement, and we went ahead with ceftriaxone acyclovir, and DEXA was continued. However, she developed deficits despite dexamethasone. That's when the scan was repeated. So I think we can show the scan number 2. This was 4 days later.
I think similar appearances on scan 2.
Yeah. So
Yeah,
and this time we did a in this scan too, because of paraplegia and bowel involvement, we did a spine stinging in this scan.
So if you see on the contrast here compared to the first one, it is more normal here. So I'm not sure the first scan is real pathological, or is it iatrogenic related attenuation of these leptomeningeal and sulcal vessels. So at least over here, you can appreciate that there is no significant enhancement on the post-contrast study on day 4 follow-up. And the spine, as Sridhar has mentioned, if you look at the cardiac nerve roots especially, we have these areas of enhancement of the dorsal and ventral aspect of the cardiac nerve roots. So diffuse enhancement out there. No focal lesion in spinal cord. Some hazy hyperintensities. I think these are likely artifactual. Yeah. So main additional findings here is the cardiac nerve root inflammation.
Yeah, so again, this 50 is the cells. So 50 cells, 564 protein and 45 sugar, again predominantly lymphocytic. However, we had done a CSF biofires by that time. It was negative CSF culture, and CSF CBNAT was also negative. It was done during the same period. So infectious process, CSF viral multiplex PCR, CSF biofires, and the CSF CBNAT was negative, and there was lymphocytic pleocytosis, so we considered it as a neuroinflammatory disease. And I took consult from one of the senior pediatric neurologists also over here, and she told that okay, change DEXA to methylprednisolone and let's see how she responds. So we changed DEXA to methylprednisolone, and then she was given a pulse steroid. And after pulse steroid, she had again seizures. So again, we repeated a scan, and this is now showing changes of posterior reversible encephalopathy syndrome.
Yeah.
This was scanned in the third.
Yeah, like an atypical kind of thing. But yeah, you can appreciate subcortical cortical edematous changes. The central changes are slightly improved. The capsular changes and the claustral changes compared to the first scan. Even the basal ganglia slightly, I mean, it is not as edematous as the previous one, but these are additional changes. Diffusion predominantly vasogenic edema, some cortical edema is there. But yeah, so on the ADCs, you can appreciate it's predominantly vasogenic in nature.
Yeah, so we also roped in ID in between. So doxycycline was also given for 5 days. However, there was no fever. So yeah, this is a third scan, and I think we again did 2 more CSFs, which showed decrease in cells, decrease in protein, and improving sugars. So the pleocytosis was improving, but on steroid she developed this. With this scan, we also repeated the spine again. The spine was showing this thickening of chorda equina nerve roots and going up to the chorda medullaris also. So this time we gave IVIG because every infectious the child was on ceftriaxone, acyclovir, doxycycline course was also given for 7 days. CSF was showing, you can see, if you see the 60, 50 and 43 are the cells. So the cells were decreasing. The sugar, the proteins were also decreasing, and the glucose was also improving. The lymphocytes were still present. So considering still neuroinflammatory phenotype, we gave IVIG 2 gram per kg over 4 days. With IVIG, she had some improvement. The ptosis improved, the ophthalmoplegia improved, the bladder sensation improved. So she was shifted to CIC. However, she is still paraplegic, and there is still mild complete ophthalmoplegia, which is still there. It's not completely reversed. INO is still persisting. However, the superior and the elevation and depression is improved. And this is the workup. We also did MOG antibodies which were negative. Ceftriaxone we gave for around 21 days. The day I posted, it was 14 days. And so overall, the phenotype is of polyneuritis cranialis, multiple cranial palsies, paraplegia with neurogenic bowel and bladder. She received DEXA followed by IVIG pulse, IVMP pulse followed by IVIG. Another thing which we noticed was she had some parotid gland enlargement. So serum amylase was done, which was mildly elevated around 254. So we did send the mumps PCR also in the CSF, but it was negative. So yeah, so it is inflammatory electronitis with this polyneuritis cranialis. So we want to know the differentials.
See that,
we did no conduction study, no conduction showing decreased Cmaps in lower limb more than upper limb. However, the afflatancies and all those things were, basically the child was not that cooperative, but yeah, it was mildly increased because the CMAPs were reduced, the afflatancies were increased in lower limbs. In upper limbs, they were normal. The sensory conduction was absent in the lower limbs, and in upper limb it was normal.
Ricketts lines.
No history of snake bite. No, it was not a snake bite. It started with seizure and no history of snake bite. They weren't. The child was in train when she had a fever and cough cold, and in train in Vadodara station only they had a status epilepticus. So she was escorted in ambulance from station to our hospital.
Yeah, and snake bites diffusion would be more significant. Predominant white matter changes.
Plex was not done. So as of now, the child has gone home only on continuous intermittent catheterization, some supplements, and we are not given steroids because press was developed, and we have called her on follow-up. She is supposed to come next Thursday. And they have started off with seizures, and then in hospital she developed paraplegia, neurogenic bowel bladder. In hospital she developed ptosis, ophthalmoplegia. And then we give antibiotics, immunotherapy, mixture of treatments, and multiple scans, multiple CSFs. CSFs were improving. I don't know what, but they were improving. Maybe the workup is not appropriate.
Why do PCR sent?
But CSF biofires was sent.
Okay.
It was entire biofires was sent, which was negative.
Was the first CSF done before the antibiotics and all that?
No. The first CSF was antibiotics were started on day 1 only because she presented status. The first CSF was done after 3 doses of antibiotics, not more than that.
MOG, Dr. Lokesh has MOG, NMO. Yeah, MOG is negative, Lokesh. I think NMO.
MOG is negative, yeah. And aquaporin 4 wasn't done. MOG was done, which was negative.
Yeah, but I don't think NMO gives root enhancement. MOG does.
MOG does. MOG is more commonly to have root enhancement. See if there's optic. I thought there was optic neuritis. If you, at least on the last scan. Was this checked for Sridhar? Any optic?
Yeah, we checked for. We did fundus twice. Fundus was not showing any papillitis or papilloedema, and our vision also was normal. It was 2 times ophthalmologists have seen the child.
Okay.
I have shared the biofiles report on the group also.
Sure. Mycoplasma, rickettsia, brucellosis. Dr. Rashmi asked if they were tested.
They were not tested, but we gave doxycycline for 7 days. And frankly speaking, there was no fever after the first 24 hours of hospital stay. But we did give. ID was also roped in. ID told to give doxy. We gave doxy also. Pardon? Basically, she is a cauda conus syndrome with polyneuritis cranialis. All this viral panel were done negative.
Negative, okay.
Any further thoughts?
Yeah.
And the explanation for this cauda equina syndrome is infection or vascular? I mean, in bacterial meningitis, spinal cord infarcts are rare but are known.
We're thinking inflammatory. Sridhar, is that right? Infective inflammatory process.
Infective inflammatory process. Yeah. But the thing is, if it was a GBS with hypoxemia, parents would have told some history during that visit. They were not telling anything. In train also, the child went for washroom by herself, came in and out of washroom by herself. She's a 6-year-old kid. No weakness at that time. Weakness was observed after 48 hours once the DEXA was stopped. That was also one of the things we kept in mind, GBS with hypoxia. That's why IVIG was given at that point in time. But GBS presenting with seizure, first up, I have not seen till now. But yeah, theoretically possible.
And by definition, GBS has not 700 cells.
Yeah, and the cells were atypical. That's what it was. The cells were too high for GBS, and even the protein 640 was the protein. First protein was very high. The 679 is the protein, and cells are 60 in the first.
I have a not very important anatomical question, yes, to this slide. Is that claustrum or external capsule or both, or can you distinguish? And does it matter in terms of pattern recognition?
I think it's more of claustrum, but on this slide, I'm not able to differentiate them. Claustral hypertendency is, I think, more commonly seen in fires-related conditions, is one of the differentials. Thanks. But they're very close to each other.
My other differential, of course, very short, is acute necrotizing encephalopathy, of course, with additional findings, and some intoxications can have claustrum involvement.
Dr. Lokesh's TB, I think TB was negative. Yeah, CSF NAT.
Yeah, we did give ATT for a while, but again she developed hepatitis, so we had to stop that. Yeah, frankly speaking, I was also not very sure down the line, so I roped in a senior pediatric neurologist over here for a second opinion, and she also thought that okay, she only told that okay, it does not look like a TB. TB does not come with a 2-day history, so ATT was stopped, and she told for methylprednisolone pulse, so we went for a methylprednisolone pulse at that point.
Question from Dr. Amta, would you consider PLEX or VSL immunotherapy like rituximab? I think child is improving clinically or not. I missed that, Sridhar.
Improving, but not completely. Not completely. She is still paraplegic. So she was not able to sit by herself during the hospital. But when she was discharged, she had truncal power regained. Upper limb was more powerful. Ptosis improved. So it was a grade 3 ptosis. It became a grade 2 on right side and grade 1 on left side. And ophthalmoplegia improved slightly. Some horizontal movements did came, but INO was still persisting. And T ganglioside we did not do. Yeah. And this was a trust hospital, so the finances were a big issue. Even today, I'm getting mails from the administration saying that a lot of bill is not yet cleared. So yeah, it was difficult. But yeah, we give the treatment for the, if we are considering it as GBS for IVIG, and steroids both are given. Rituximab I won't consider because actually I don't know what I'm dealing with. So it will be very difficult for me to consider any other immunotherapies.
Actually, if you look at the distribution, you have brainstem and spinal cord, and you have root enhancement. So enterovirus, would be the first, I think. You have done an AFP, you must have done an AFP, right?
AFP we have done, yes, sir. That's negative.
Follow with them and see if there's some non-polio or one of those funny viruses which are doing.
Yeah.
I don't know whether it affects the colostrum. I don't know. I know how. I know the enteroviruses affect the brainstem pretty commonly and the spinal cord pretty commonly, and also, of course, the roots.
But here, I don't think the brainstem. Yeah.
But here, clinically brainstem, no?
Yeah. Neurologically, I'm not yet. And the
clinically brainstem, but not brain. Yeah, clinically brainstem, but we thought more like a nerve entrapment outside the brainstem, and the nerves are in the space, in the subarachnoid space. They are getting.
INO, no? INO is very. Typical.
INO, yes.
Yeah, that's not in the outside.
Yeah, INO is very internuclear ophthalmoplegia. That is very typical of a brainstem thing.
Correct. So I
but
think
that's what in 3 scans.
Possible, and the only thing is the enterovirus PCR may be negative in the CSF because it's a very transient thing, and mainly after that it goes in you can pick it up in the stool or in the nasal swabs and all that. You may not pick it up on the. Anyway, possible.
Yeah, so Enterovirus, any specific, sir, any specific treatments which could have helped, or it is just we have to wait for the time to heal?
There's one drug called Picarnovil or some Picarno. I think it's not available anywhere. Even in the
Okay.
US, we had a patient with enterovirus encephalitis subacute because of immunodeficiency. And we tried to get the drug and it was just not available anywhere. Even though, it's very difficult to get. So there seems to be some improvement with that, but that's really anyway.
Yeah, I have seen one enterovirus meningoencephalitis in a child with common variable immunodeficiency.
Yeah.
That also, that
Yeah,
time also, yeah.
So that's a subacute, enterovirus encephalopathy, and it comes mainly with
Yeah.
dementia and stuff like that.
Yeah, dementia and stuff, and that child had hydrocephalus.
Oh, I see. Okay.
Yeah. That child had hydrocephalus, we had to shunt him. And the CSF done at the time of hydrocephalus picked up enterovirus in biofires. So we did not get antiviral drug, but the ID told that there are some studies of fluoxetine working in enterovirus thing. We gave fluoxetine and somehow his behavior and dementia symptoms improved. So we were continuing that. This was in CMC Vellore. Neither of us know what helped the child.
Yeah.
And the child was already on monthly IVIG also. So the thing was, he was on IVIG every 1 monthly, and then the ID and him had changed it to every 21 days, something like that.
Yeah.
The last time I was there in CMC, I saw that the child was walking around in the OPD. So yeah.
Oh, good.
Yeah.
Okay.
Okay. Let's see. David Cummins looks infective and more than inflammatory. Did we treat for HSV dose of antivirals?
Yeah, we did give acyclovir for 14 days. We gave acyclovir for 14 days. That's what I'm saying, that we treated whatever possibly could be treated, but however, it was not like we don't know what we were dealing with finally. So that's why I put up the case in the forum. But we gave antibiotics, antivirals, anti-rickettsial, methylpred, IVIG, everything.
Yeah, I think we agree with the spectrum of disorder, but not the organism. We're not able to point it out.
Yes. Yeah.
So anyway, if the child is improving, then maybe you can get a follow-up later on.
Yeah. The child will come on follow-up. We'll surely. We just hope that nothing more comes up, and we just get.
Dr. Rashmi praises you, but you have done your best. Typical case. Yeah.
Thank you. Thanks a lot.
Yeah, thanks, Sridhar. Yeah. All right, we'll move on to Darshat from Anandpur, if you're there, or Dr. Vishnu.
Hi, sir. Yeah.
Yeah, Darshat, go ahead. Yeah.
This is a case of 2 year, 7-month-old male child who was born out of a second-degree consanguineous marriage, second by birth order, was brought to the casualty on the 22nd of May at 6 a.m. with complaints of multifocal clonic seizures. There was no postictal weakness. A child had a history of fever 2 weeks back, which lasted around for 1 week and got subsided, followed by a decreased activity, difficulty in walking, which presented as standing with support, slow walking, and not able to run. This was the present. Child had a similar type of seizures on 25th of March, for which they were admitted at government hospital and were admitted and started on Levipil. At that time, the imaging was done, which was normal. They were discharged with oral Levipil. There were no perinatal issues and the development was normal. Anthropometry was less than third centile. On examination, prominent forehead, clinodactyly, and central hypotonia were observed.
Okay. Anything specific on the seizures, or just?
Yeah, there are multifocal clonic seizures, sir.
Okay.
So they are refractory on admission.
Okay. All right. So there are around 4 or 5 sets of scans. The first scan at this point of time was normal. We have a follow-up scan. How many days later? On May 22nd.
In
May.
March, they had one episode of seizure.
Yeah.
That time MRI was done at government hospital. That was normal. So this is the second episode that happened in the May. So
Okay,
in
so this
May,
is in
they
May.
admitted refractory focal seizures. So at the time, the second MRI, which was
Yeah.
done at RDT,
But no fever, no, only
no fever,
seizures.
sir. That's what fever was there before 2 weeks.
Okay, okay.
After that, there is a decreased activity, no playfulness, and there is a difficulty in walking. So with such sort of a progression, child started to have these refractory seizures. Then they came to us.
And the
this is-
interval to the second MR is how many days?
Almost 2 months, sir.
2
That is
months.
March, sir. So this is May.
Thanks.
All right. So we'll look at the scans in May. Yeah, T2s and flares. You have predominantly multifocal cortical hyperintensities involving the bilateral hemispheres, frontal lobe out there, parietal lobe, and also the temporal lobes and the paramedian occipital lobe. Some faint hyperintensities in the thalamus on both sides. Posterior foci, I do not appreciate any significant findings. But these multifocal, predominantly cortical hyperintensities were demonstrated on the bilateral hemispheres. On the diffusion and ADC, some of them demonstrated restricted diffusion. You can appreciate that on the temporal regions and also some degree in the parietal lobes on the left side. Yeah, midland SAG, yeah, I do not appreciate any significant findings. This partial empty cella, likely normal variant with frontal bossing. So at this point of time, I think we're thinking of possibilities of infective and para-infectious demyelination. Is that right? As one of
Yes,
the
sir. Yes, sir.
possibilities.
Yeah. So in the same line, we started methylprednisolone, but child
On day 3 of admission, a sensorium was decreased and right hemiparesis was observed. Sir. EEG was done, which was associated of diffuse slowing, and for that MRI was also repeated. Sir.
Okay, so right hemiparesis is now a new finding and
yes, and encephalopathy.
and encephalopathy. Yeah. Anything on the video specific?
No, sir. Same seizures were
Okay.
continuing, and there is right hemiparesis. Sir.
Then we have an interval scan. I think I've done almost a couple of weeks later, 22nd to 2nd, so 10 days interval scan.
Yeah, yes.
There's progression in the lesions, as you can appreciate here, more confluent changes in the bilateral hemispheres, frontal lobes, parietal lobes. Now additional changes in the basal ganglia, especially on the right side. You have this focal abnormality in the caudate. Thalamus also has some patchy hyperintensities. In terms of the cortical involvement, in comparison to the previous scan, there is progression in terms of changes. Posterior fossa, again, not very significant findings, maybe some early changes of circle prominence or reduction in volume in the inferior cerebral hemispheres. On diffusion variant sequences, yeah, most of the new changes demonstrate restricted diffusion, especially on the left side, and also the right globus pallidus abnormality demonstrate restricted diffusion.
See, in case of in view of the fever specs, the CSF analysis was done, so which was normal. A serum MOG NMO was done, which was also normal, and lefty lactate were done. So, CSF NMD antibodies were also negative, sir. Immunomodulation was given in form of methylpred, IVIG, and rituximab. The sensorium gradually improved, but a child had cerebral vision impairment. Seizures were controlled, and the child was discharged on oral prednisolone and anti-seizure medications. Before discharge, the age still showed diffuse slowing, but frequency improved.
Okay. Yeah, so these are the follow-up videos with some improvement rates.
Yes. Next slide.
So 2 weeks, yeah.
2
Sorry,
weeks
go ahead.
of discharge. Yes.
Go ahead, Vishnu.
The child was readmitted with a depressed sensorium and refractory left focal seizures.
Okay, only seizures, no
Admission,
fever.
they were refractory right
Right.
focal seizures.
Right focal.
Now, child presented with acute onset difficulty in feeding. There is drooling of saliva and swallowing difficulty. And within a few hours, child started to have left focal seizures. and those seizures were very refractory.
Got it. Then we have another scan done at the time of the latest episode. Majority of the changes demonstrate chronic findings. You have glycosis, some degree of encephalomalacia out there, especially in the left hemisphere. And there's also an interval reduction in the cortical cerebral volume. Also, you can appreciate again the sulcal prominence is slightly more than the previous scan, so some interval change in the cerebellar volume also. Let's see if there are any diffusion changes. Yeah, this scan does not have any significant changes on diffusion compared to the prior study. So the prior changes have changes of chronicity with the interval reduction in the cerebral and cerebellar volume. Contrast study was done, and no enhancement on contrast. Yeah, midline sag, you can appreciate the thinning of the corpus callosum and also some folial prominence along the epidermis out there.
Sir, in this image, the
Yeah.
flare perisylvian hypointensities were there. There's
So
some
this is
rarefaction.
this is contrast. Let's see. Yeah.
Yeah.
There's
So
volume
flare
loss. This
it
is okay.
Yes, sir,
Yeah.
that
This is
one.
this is partialing. This is not encephalomalacia. This is just the way the sequence is. It's not. It is more the encephalomalacia is more along the frontal and the temporal lobe. This is just a volume. This is not encephalomalacia. If that's the question.
Yes, sir, yes, sir. Why that rarefaction is being seen?
No, it's not rarefaction. It's just a partialing of the sulcal and the cortical area out there. If you put a sag and a coronal at the same level, you'll only see the sulcal spaces. You see on the
Okay.
T2s also, so you can see there's hazy appearance out here. So that is just partial voluming and not true findings.
Can you show the second scan, please?
Second one, let's see. This
There
is the
was,
second
I think, was there anything in the motor cortex? Yeah. So this looks like Alpers, no?
Yeah, that's what we are thinking. Yeah, again, I mean, few more scans. Alpers.
Okay.
So this is the one. I think we have one more scan after this. So LFTs and lactate are normal. Is this serum or CSF lactate?
Yes, serum, sir, serum.
No, we need to do CSF.
Yeah, we have not done, sir.
Okay. Then again, there was one more scan, the most recent one. Anything in between, Dashrath?
No, sir. There's just a child continuously having those focal twitchings, and encephalopathy is not improving.
Okay. Now you can see the anterior hemisphere as diffusion changes, the perisylvian regions, new changes, new interval changes out there. The basal ganglia thalami also has this area restricted diffusion. So new abnormalities in the most recent scan, I think done yesterday. And this time they did a spectroscopy. So this is in the normal appearing brain, and these are the abnormal areas on below. You can appreciate even in the normal appearing brain, there is lactate peaks, inverted lactate out there. And in the abnormal areas, there is significant inversion of the lactate out there. Some reduction in the
mitochondrial melas. That's why we sent MRS for this.
Yeah, so query is, thinking is this mitochondrial? If mitochondrial, does it fit into the Pol-G variant, which can also have these changes? But hemiparesis, is it possible to have this atypical variant of melas, given these multifocal appearances, migratory changes, which the child had on the sequential scans? So are we thinking in terms of mitochondrial as one of the possibilities, given the child also had microcephaly?
Yes, sir. Microcephaly is there. Consanguinity is also there.
Yeah.
We sent mitochondrial genome analysis report is awaited.
Yeah.
Nihaal.
I'll open the case.
No, mitochondrial genome may come negative. You may do the whole exome.
Yeah, yes, sir. We sent both, sir. WS and mitochondrial.
In my opinion, the marked difference between MR1 and 2 in, say, 1 week or 10 days is not in favor of a genetic condition. I have great doubts. This is an acquired condition as a hypothesis.
This is at a time of first admission.
So this is second admission. These multifocal changes. Then
there is a right focal right hemiparesis and encephalopathy, and this is the second MRA.
But everything has turned out to be negative. I mean, CSF, serum.
Yeah, so there is no pleocytosis, there is no increased protein in CSF.
I mean, they can be seizure-related changes, but refractory seizures continues. Was the query which raised the possibility of inherited disorder. Okay, let's see if anyone else on the chat. Sridhar says Bogolji, Melas possible, Anish Bogolji. Shika says channelopathy, sodium channelopathies. CSF protein, normal as mentioned. Okay, Dr. Namrata also says possibly Paul Alpers. Dr. Udani, sorry, you were saying something regarding the testing?
No, I think they've said the WS in the mitochondrial genome as well.
Yeah.
I'm very much interested in the result. I'm still sticking to a non-genetic disorder due to the rapid change initially and then the fluctuating change later. Is that typical for a metabolic disorder? Genetic?
Melas, maybe.
But Melas, I mean, this is, of course, I have not seen hundreds of Melas, but this is not a stroke-like pattern you have seen in that patient. It's multifocal. And it's, has it, yeah.
Yeah, multifocal,
Well,
the atypical one has multifocal. The Melas, the atypical variant. Usually the younger child have these multifocal abnormalities.
And here also predominantly cortical gray matter involvement is very predominant, no? Cortex basically.
Yeah, cortex, yeah. So this is the more classic Melas, which you see as most like the stroke-like variant, but usually the younger children can have these multifocal abnormalities. And they are usually seen in the respiratory chain genes. So maybe you can ask them to target these genes.
Yes, sir.
Okay.
Yeah. Thank you, sir.
Yeah. Okay. Anything else on the chat? Let's see. If anything else, yeah, I think, yeah, most of them have seen a possibility of mitochondrial. Okay. Okay, Dashath, we hope you can enlighten us with the final
sure, sir.
diagnosis.
We'll update the report.
Thank you.
Thank you.
Thank you, Vishnu. Yeah. All right. Back to Hyderabad. Harika, if you're there, over to you.
Yes, sir. This is a 3-year-old male child born out of non-consanguineous marriage, second in birth order, with no perinatal issues. He had they have brought the child with the complaints of motor development delay, which on examination head circumference was 48 and normal dermatoglyphics, no neurocutaneous markers. There was short stubby fingers and a slightly blue sclera was noticed, and intermittent esotropia was there, and short stature was there, but good eye contact, extraocular movements are full, and speech was normal. There was central hypotonia and broad-based gait was there, and there were intentional tremors while approaching the objects, and also while standing there was tremulousness of both the legs.
Sorry.
So with this, because of motor development delay and this cerebellar signs of broad-based gait with intentional tremors, and this some dysmorphic features of hands like short stubby fingers and intermittent, slightly blue sclera, we have done MRI brain.
Suspecting genetic etiology.
Yes, sir.
Okay. All right, MRI brain T2 and diffusion various sequences, predominant changes in the brainstem. You can appreciate here T2 hyperintensities along the midbrain, going up to the infraspect of the red nucleus, the central tegmental tracts, and the medulla, and also the cervicomedullary junction. And these changes demonstrate restricted diffusion, corresponding area restricted diffusion, punctate abnormalities in the epitome on both sides, but predominant changes are in the brainstem. Some degree of anterior vermis volume reduction, but yeah, predominant changes in terms of signal abnormalities in the brainstem, as mentioned here, and with the corresponding area of distributed diffusion. On the SAT sequence, you can appreciate the patchy involvement of the brainstem and also some areas of involvement of the cervical cord. No necrosis or hemosiderin deposits in the corresponding changes out there. Spectroscopy, again, this was in the basal ganglia. You have a slightly small inverted lactate, but this MRS was placed in the brainstem abnormalities, and you can appreciate again a significantly inverted lactate out there. With this imaging and the clinical presentation, we were thinking of possible mitochondrial disorder, SERF1 mutation. Trial was sent for whole exome sequencing, and
Yes,
Harika, you can.
whole exome sequencing was also assessed to homozygous SERF1 mutation, mitochondrial complex 4 deficiency, nuclear type 1. And we have done serum lactate that was 3 millimoles per liter. CSF lactate was not done. We just want to share this case because clinically and radiologically it is matching with mitochondrial disorder.
Yeah, particularly SERF1 COX-related disorder, which have related sparing on the basal ganglia. I think that is one of the clue, and predominantly involved the brainstem with the lactate. If anyone
Thank
wants to
you.
come in,
Very informative. Very good match.
yes. Right, Khalid also
Any
agrees.
other imaging features? Any other imaging features for SERF1 and any other differentials for this kind of imaging pattern apart from SERF1?
In terms of mitochondrial, I would go with SERF1 only, Abhishek. Dr. Abhishek, yeah.
Okay.
I'm not aware of any other findings. Maybe tRNA disorders, but they usually also have corticospinal tract supratemporally, the plics and all involved, but it is pretty pathognomic in terms of imaging findings with the elevated lactates which we have seen.
Okay.
I think other early onset severe so-called Lee cases can have a similar imaging pattern, but in doing the genetic testing, you would find out whether it's SERF1 or one of the others. This is very likely or clearly suggestive of a mitochondrial disorder. Autosomal recessive. Nuclear DNA.
Right. Yeah, thanks again. Thanks, Harika and Dr. Abhishek. So yeah, I just wanted to show that case. All right, we'll move on to our next case. Harika, over to you.
Yes, sir. This is a 13-year-old boy born out of non-consanguineous marriage, first in birth order, no perinatal issues, normal development, good at academics, and he was right-handed. In Jan 2025, he had acute onset walking difficulty that was progressive. He initially had difficulty in wearing chappals and holding the chappals, and that was increasing in severity. And after 1 week, he also had difficulty in holding objects with left hand. There was poor grip, but there was no difficulty in reaching overhead objects, no difficulty in getting up from the floor. And this was progressive for almost up to 3 weeks. Actually, this child was from Saudi Arabia, so they have shown there. And child was started on steroids. So this child came to us in May 2025. By that time, we have seen this weakness is also improving.
Okay. So you want me to show a scan first? All right. So May 2025, we have two sets of scans. This is the first one which we have on file. But if you appreciate on the flare sequences, if you look at the insular cortex, there is hyperintensity out there. Also around the posterior putamen, and you can appreciate the marked arrows here, the thalamus, and also the septum semiolus, the coronary area has these white matter changes. I mean, the hyperintensity changes on flare sequences. Septum semiolus, right thalamus, insular cortex has predominantly these hyperintensity changes. Posterior fossa, I think, is okay. Some hyperintensity is also on the contralateral side. If you look at the posterior putamen out there, and also the white matter, peritrigonal white matter, there's some hyperintensity. And some focal abnormality in the superficial frontal white matter on the left side. So these are the main findings I'm able to appreciate with some degree of cortical volume loss. The coronal and the SAD sequences on the side, again, you can appreciate the findings marked out here, predominantly on the right side. Post contrast, I have only coronals, and on the coronal sequences, I think also axles, but coronals, I don't able to appreciate any significant enhancement. The axles, those changes do not demonstrate any enhancement out there. Spectroscopy was done, which did not demonstrate any significant peaks. Angio was done. I think angio also does not demonstrate any significant stenosis or narrowing or thrombosis. So predominantly some multifocal abnormalities, predominantly right-sided. Insular, thalamic posterior putamen and the deep white matter center of semiovale involved on the right side, and some focal abnormalities on the left, peritrigonal lesion and the left superficial frontal white matter, with no enhancement and no angiographic abnormalities or no spectroscopic abnormalities. Thinking of infectious, parainfectious, Harika, and I think this is May or Jan. No, sorry.
Sir, this was in Jan only, sir. It was done
Okay.
outside.
Okay.
So CSF analysis was showing protein of 55 and glucose of 65. They have done anti-NMDA also, that was negative. And ANA was also negative, ESR was 10. We initially accounted this left hemiparesis, but that was improving within 3 to 4 months due to these structural changes in right superior parietal region. But again,
structurally, you mean like a malformation or?
so like as it was reported as FCD, small FCD. So
Okay.
we thought it may be due to this structural lesion.
But there's also white matter involvement, no? I mean, you come on top over here.
Yes, sir.
And contractually also, I think one over here and
FCD
anyway.
coming only with the hemiparesis, not seizures.
Only hemiparesis.
Oh, it's unlikely to be FCD.
Okay. All right. So before the child came, I mean, they are given the FCD. All right.
Child was already on steroids. He used
Okay.
steroids for almost 8 weeks. That was improving.
And then I
And
think we have,
again, in July 2025, he presented to us with sudden onset of drooping of right eyelid since 10 days. And this ptosis had no diurnal variation, not associated with any fatigability or weakness. And was examination, his higher mental functions were normal. And right eye ptosis was there. No fatigability was seen. And there was restriction of extraocular movements with elevation of -2, depression of -1, and right adduction restriction. As we see in this video, there is restriction of right eye adduction and also elevation. And left eye extraocular movements were full, and tone and power was normal now, and but there was left pronator drift, and mild circumflexion gait and loss of associated movements were seen on left side. And in view of suspicion of myasthenia, we have done fatigability test that was negative, and we have done NCS and RNST that was also negative, and anti-muscarinic antibodies, anti-acetylcholine receptor antibodies was done in your suspicion of myasthenia. That was negative. And ISPAC test was also negative, and anti-thyroid antibodies also negative. Serum calcium was normal, ANA profile normal, and ACL levels were also normal. And this drooping of right eyelid is still persistent. There is no progression or improvement in this right eyelid ptosis and extraocular movement restriction.
What is the pupil like?
So pupils are 2 mm reacting to light, so there is no anisocoria.
The question is because of the midbrain lesion, right?
we have one more scan, I think. Yeah. So this was in July, a follow-up scan. Again, flare non-contrast. We have some abnormalities out in the brainstem, going up to the middle cerebral peduncle on the left, especially on the left side. Pons also have a dorsal pontine abnormality, and also midbrain on the right side has these hyperintensities out there. The insular cortex and the thalamic abnormality is still present, which we have seen previously. The one in the coronary data and the central female again has these focal changes on flare signals. To see if the brainstem was there previously. Yeah, the brainstem findings, if you see on the flare sequences, are not as prominent or significant as seen on the follow-up scan. So there are new changes. New changes on the follow-up scan, especially in the posterior fossa, that is the brainstem. I think oculomotor nerve was assessed for any compressive neuropathy. I think we don't have the sequential scan, but it was mentioned as normal. I do not appreciate any findings of compressive vascular findings out there on the oculomotor nerves. Looking for myasthenia, I think the extraocular muscles do not appear to be abnormal. Optic nerves also, in terms of signal changes, do not appear to be edematous, and post contrast. I do not appreciate any significant maybe in the orbital regions. On the right side, there's some perineural fat stranding. Yeah. Yeah, fat side sequences again on coronal sequences. Extraocular muscles appear to be normal. The right optic nerve appears to be slightly abnormal out here, especially in this section. So additional findings on the brainstem, possibly of the optic nerves, with ocular muscles and the nerves appearing to be normal. So now the query is, yeah, sorry.
Our query is like whether it is demyelination by any multiple sclerosis. We have done serum NMO that was also negative. So because he initially had left hemiparesis that had improvement, almost now near recovery. Again now presenting with new onset symptoms with the right eye ptosis and extraocular movement restriction. And we have worked up for myasthenia, and child was started on pyridostigmine also, but no improvement. So should we do anything further, or
Dr. Lokesh asked, can data to present like this? Is it clinically or radiologically?
Yeah, theoretically and also clinically, they can have Turner palsy because brainstem syndromes are known with DADA2 mutation, but it doesn't have any other systemic manifestations as of now. No Raynaud phenomena, no failure to thrive, no other skin abnormalities. So that is odd. He's well thriving child, doing well and going to school regularly.
If there were some hemorrhagic changes, I would have been more confident for to Lokesh.
We have not done any systemic imaging to look at the this one nearby Dopplers or other things, vascular abnormalities in the kidney, blood vessels, and other things.
DTR's question from Dr. Namata.
Yeah.
Normal. Any skin manifestations? I don't think so.
no skin manifestations?
AC levels also are normal.
Yes, sir.
Rajesh, any input?
Well, I was thinking actually initially of demyelination.
Yeah.
But the CSF protein also is slightly high.
Yeah.
You know, you've done the OCB and all that stuff?
This time we have not done because the initial acute event was there while in Saudi.
But he's got, but he's got recurrent, disseminated space in time. He's got some, some of those white matter lesions are perpendicular dorsal fingers kind of things.
Yeah, this one especially out here.
Yeah, I saw them yesterday actually again on follow up. So I said we'll discuss in a meeting and then get back to them tomorrow.
Epstein-Barr virus tested?
No, not been tested.
I think it might be worthwhile.
Yeah,
given this pattern out here.
This one Epstein-Barr virus as well.
Yeah.
Oligoclonal bands and VEPs.
Yeah.
Yeah. Thank you.
Thank you. All right.
VP, we can do VP and C.
Yeah. Yeah, we are doing it tomorrow.
Yeah.
Okay. Over to Nagpur, Dr. Chika, Dr. Apurva, if there.
Good evening, everyone. So we have a 15-year-old boy who first presented to us 30th of July 2025. He's symptomatic from last year June. He is a premorbidly well child with above average scholastic performance. He started developing difficulty in coping up with studies in school and coaching institute. This was attributed to his admission in new coaching institute. But subsequently, parents noticed that he has started appearing withdrawn, lost in thoughts, and this was again attributed to academic struggle. His atypical behavior started to develop from last 8 to 9 months. In October 2024, parents noticed that he is taking long to do his activity of daily living, such as brushing his shirt, brushing his teeth, buttoning up his shirt, and etc. He was reluctant to go to school. For this, multiple counselors and psychologists were consulted, as parents, father is a pediatrician and mother is a behavioral therapist. His symptoms persisted, and in December 2024, parents noticed new symptoms in the form of blank stares. He would develop atypical body posturing intermittently in the form of stretching of fingers and toes. There was decreased spontaneous motor activity, and he's also started having self-gratification behavior and intermittent bowel and bladder accidents. In March 2025, he was finally started on SSRIs, but this did not help him at all. There was worsening in his behavior. He developed selective mutism, increased clumsiness, his gait became drunken-like, there was skin picking, and by June of 2025, his SSRIs were stopped. Presently, the child is able to eat independently but becomes messy. There is clumsiness in his motor movements. There are some facial grimacing that parents still report. And the bowel bladder accidents are still persistent. The self-gratification have reduced, but they are still present. There is no history of any seizures or history suggestive of any myoclonic jerk. On examination in our OPD on 30th of July, he was alert, conscious, and there was stereotypical. Yes, sir.
No, sorry, go
ahead. He was alert, conscious, stereotypical facial grimacing were noted. He was not responding consistently to commands. There was ataxia. He also had bradykinesia, and intermittent posturing of fingers and toes were noted. His reflexes were normal. Because of his symptoms and no relief with antipsychotics, parents finally did his neuroimaging, and subsequently they also did multiple blood investigations. As he had self-gratification behavior, several hormonal workup was done.
We'll get to that
after imaging.
Yeah.
Yes, sir.
But clinically, any possibilities on this presentation?
Yes, sir.
Predominantly,
he already had come with a lot of investigation. We kept a syndromic diagnosis of progressive neuroregression with cognitive decline, ataxia, prominent neuropsychiatric behaviors, and extrapyramidal involvement. He had already come with our investigations, and then after looking at investigations, we further did some more clinical examination. His fundus and everything was normal, but there was slight asymmetry in his testicular volume. We today we have ordered a US.
Okay, we'll get to that.
I will be telling it.
Yeah. Yes. But the child was never sick or febrile or no encephalopathy at any point of time?
Sir. No, sir.
Okay.
No, sir.
Yeah, fine. Okay. So with that, we'll move on to the imaging. Yeah, so these are the main findings for the child. There was generalized reduction in the volume, but the main findings are these bilateral basal ganglia capsular abnormalities, some T2 predominantly demonstrating T2 apparentity, some fluid levels on the right side, some internal septations on the left basal ganglia abnormality. On diffusion wave sequences, peripheral areas, at least the wall demonstrated restricted diffusion. And on the GRE sequences, we have again the peripheral areas have the areas of blooming, which the left one goes down up to the medial temporal lobe, the amygdala, compressing or pushing, indenting on the left half of the midbrain or cerebral peduncle. This is non-contrast T1. You can appreciate some areas of hemorrhage out there, especially on the left basal ganglia abnormality. And on the post-contrast sequences, you have these peripheral areas of enhancement out there. If you look at the T1 sequences, non-contrast, contrast, there is definite enhancement around the periphery. Pituitary gland, though in terms of volume, did not appear to be abnormal, but there was some maybe possible thickening out there of the pituitary stalk. So we didn't have a T1 non-contrast sequence, so only a post-contrast sequence, and not a dynamic study, just a normal post-contrast sequence was done. CT scan also was done. I have pixelated images taken from a video, but if you see the periphery of the areas of the abnormalities, there is some calcification out there. Appears to be calcification or mineralization, at least on the periphery. With that, I think the child was investigated or came with investigations. Yeah, over to you. We'll go through the investigation and come to a discussion after that.
With prominent neuroregression and prominent neuropsychiatric manifestations and cognitive decline. He was worked up for Wilson disease, which was normal. And there were calcifications noted in the CT, so PTH and calcium phosphorus level were done, which was again within the normal limit. The purpose which parents told us of doing his hormonal workup was his self-gratification behavior. However, we noticed that his prolactin was elevated. Initially, we attributed prolactin elevation to SSRI use, but he also had significant elevation of estradiol, and testosterone was also elevated markedly. He is according to Tanner stage, he is in SMR3, and along with elevation in testosterone and estradiol, there was suppression of LH and FSH. So then we thought of and there is some apart from HPG axis, there is some mass or some lesion which is secreting some HC, and that is acting like Leydig hormone, suppressing endogenous LH, and also stimulating testosterone production in Leydig cells. The asymmetry clinically was not significant, but today we have gotten his USG scrotum done, and his left testis is 7.5 cc, and right testicular volume is 10.3 cc. More than 2 ml is considered significant. But we could not, initially we were thinking if we had kept a possibility after imaging a possibility of CNS germ cell tumor, but with some peripheral tumor and central tumor, that does not explain everything, sir.
Okay, so imaging wise, I thought one of the possibilities were germ cell tumors, as you mentioned. So these are cases, but predominantly we have seen, experienced unilateral lesions, which usually have cortical atrophy on the same side. So if you look at the panel on top on the first case, it appears to be pretty similar to what we have seen in our child, but this is, as you can see, is more unilateral involvement. But these can be cystic in nature. These can have calcifications and hemorrhage. And given that the endocrine abnormality, I think possibility is to be kept in mind. The other possibility was cavernomas, but bilateral basal ganglia cavernomas, I have not come across these findings. So the case is open. If there are any other possibilities or any other thoughts, welcome to let us know.
What do you think of the blood level? Not the blood, but the level. What is that level? What is that due to? There's some fluid over there, isn't it? Cystic, right? So there must be some fluid. And
yeah, there is some fluid.
Is it some? Is it blood or what is it?
It is corresponding with the blooming on GRE, so it is likely blood.
Yeah. Could it be some hemorrhagic mets? But it's very long history, right?
Melanoma, I think, was thought of as one of the possibilities, and hemorrhagic mets, but I think child.
It's a very long history, unlikely.
Yeah.
And sir, meds just restricting
No, I
basal
agree.
ganglia with symmetrical.
No, because germinoma is fine, but bilateral like this, symmetrical. You sure it's a neoplasm or it could be something inflammatory?
But 9 months duration, that was again, and now it's also showing diffusion changes. Would have been more acute for a inflammatory or
acute one, some sort of parasitic or God knows something.
Yeah, but the child was never ill, if I'm not mistaken.
No, never ill.
Yeah.
He hardly had a URI in between the illness in November or something.
And cavernomas only located to brainstem, the basal ganglia without any other further involvement. I have not seen them.
I think cavernoma is very unlikely.
Yeah, they usually have more brainstem involvement, more edematous scene is associated with, especially these such a large lesions.
It's so weird. No? It's a cognitive behavioral kind of neuropsychiatric presentation with Parkinson's and Parkinsonian dystonia syndrome, and so I was thinking of something. This is a big surprise. This big.
MRS has not been done, I think, but still, that can be done, or biopsy. I don't think the lesions are amenable for biopsy. They're pretty internal.
Stereotaxic biopsy can be done, but
stereotaxic biopsy should not be a problem, especially the left one, because the right one is more, you probably get nothing or some blood over there, but the left one is.
Yeah, left one I think can be done. The cavernoma was thought of, but the entire picture doesn't fit cavernoma, is what I mean. At least that is what I thought. Psychiatric conditions, the hormonal abnormalities, the testicular abnormalities, I think, and also the imaging, if you see, it appears to be somewhat similar. The only unilateral basic ganglia germinomas, we have seen only unilateral ones. So this has
No, I think Shilpa also has given the thing about basal ganglia germinoma.
Yeah.
We had one which came with atrophy on one side and then germinoma later. But then the second scan showed the right side also. Remember, Shilpa? Yeah. So it was the left and then right. Of course, it was not simultaneous. Yeah. So I think it may be a germinoma. Maybe a CSF. I think it's safe to do a CSF. We can do those markers.
The AFP levels,
HCG, what
AFP,
HCG and all that stuff.
Yeah.
In the CSF.
I think if that is inconclusive, then we can do a stereotypic biopsy. Dr. Shilpa, she has presented with neuropsychiatric symptoms plus EPTs. Parasitic presentation, no illness, Dr. Rashmi.
Very interesting.
Ata has, I mentioned something. Yeah, otherwise I made you a panelist. If you can just. Curious case ignorant innocuous presentation, thinking Labron. Classification is pretty much, as you mentioned, chunky parasites, odd appearance, but no scolex. Methanol toxicity, I don't think. There was no toxic products there. Trace elements, heavy metal was normal. Germinoma, as you have shown, is a good thought. CSF markers will be an excellent next step. Any role for FDG PET? You've got the ultrasound for the testicles, so that I think is any lesion in the testicles or just enlarged?
No, sir, no lesion, only enlargement. Asymmetrical.
I think we can start with the CSF markers.
Yes, I think, yeah.
And then maybe if it's not conclusive, then the invasive approach.
Hi, Nihaal, can you hear me?
Yeah, please go.
No, thank you for inviting me. When was this scan done?
It was done on 26 June, sir.
Okay,
so 8 months, 9 months.
26 June 2025. For
9 months later.
Yes, sir. Okay. For 9 months, he was just being treated for psychiatric symptoms. They were attributing it to academic struggle.
We don't have any prior imaging apart from this scan, which was okay. So it's been over a month now, isn't it?
Yes, sir.
Over a month.
Yes, I'd be tempted to do a short interval scan to see where we are, whether there's any rapid progression or interval change. And maybe at that time, I don't know whether perfusion or spectroscopy could be done. Just thoughts, I'm not sure how much it'll add, but worth thinking.
Spectroscopy can be done, if it's available. I think the follow-up scan is spectroscopy.
Yeah, it's available. Yeah.
So more than 1 month interval period, right? So we can do a interval scan. And
have they had any systemic imaging for paraneoplastic workup and other?
They have done an ultrasound scrotum, which the testicles are slightly enlarged, asymmetrically enlarged.
Okay. But in terms of abdomen, pelvis, chest?
Sir, we will be going ahead with it from tomorrow.
Okay. Yeah, I think PET is a good thought as well.
But sir, my doubt is this GCT or CNS GCT, or we should look for tumors elsewhere and do like do scanning for abdomen and pelvis.
I don't know. It's very unusual for a paraneoplastic phenomenon, isn't it, Nihaal?
Yeah. But you can just do an ultrasound if that's okay, to screen the solid organs. And then interval neuroimaging scan. That should be the next step, I think. With spectroscopy and perfusion, as Athas mentioned. And then simultaneously do the CSF markers.
Yeah. Does he need a general anesthetic? How old is he?
I think 15.
15-year-old.
Oh, 15. Okay. So he doesn't need a GA.
But he's not cooperative, I think. So
Or
he
is he?
might require, yeah.
Did he have a GA for that scan then?
That we are not sure because it was done outside. But currently he's not cooperative. He's like, he's having quite a lot of, I mean, responses are very inconsistent.
Restlessness. Mm.
So I think the first possibility will keep as germinoma and second as cavernoma. Is it
No.
okay, Dr. Nihaal?
I wouldn't go with cavernoma, but yeah.
Okay. Okay. Yeah, okay. Then we'll repeat our scan with MRS
Yeah.
and we'll do CSF markers.
And ultrasound and a chest scanning, yeah.
Yeah, sure. Then we'll get back.
We can do that, or we can discuss that on the next meeting if you have the
Yeah,
interval
sure.
scans.
Sure. Okay. Thank you so much.
Thanks. Thanks, Ata.
Thank you.
We have the last scan, follow-up scan. I think it's another interesting case with multiple imaging. Harika, if you can just summarize it quickly. This was discussed previously, I think a month back.
Yes, sir. It was discussed on 4th of July. This child history started from May this 2025 with a headache that was persistent for almost 10 days. So they have been taken to local hospital. Then child was treated as ADEM or viral encephalitis and given IV methylprednisolone pulse dose with antivirals, but still no improvement in headache. So repeat MRI scan was done. And
I can just show the initial scan. This was in May. And in May, you had these multifocal abnormalities, predominantly in the deep brain nuclear structures, and also the temporal lobes demonstrated these hyperintensity T2 sequences. And there was brainstem and cerebellar involvement, patchy involvement in the cerebellum, and also brainstem involvement, as you can see on the SAT sequences, predominantly in the pons. At this point of time, I think the child was being treated externally at another hospital and was being treated for, as Harika has mentioned, ADEM and parainfectious inflammatory demyelination conditions. Post contrast, I don't think there was any enhancement, significant enhancement of the parenchymal abnormalities. Spectroscopy, I think there was a, there's a slightly large choline peak, but the creatinine and AA ratios are within the limits. Harika, I'll just take over this in point of time. So investigations were done, extensive investigation was done. CSF could not be done because there was some consternation at that point of time, but very fast NGS had the Oropoch virus, which I think later on came out to be negative. Is that right, Harika? We tested, was it sent to some other center?
Sir, we have not repeated this.
Okay, all right. Yes. All right. So yeah, so autoimmune paraneoplastic panel was negative. Child was on steroids, and then was readmitted a month later. And on the month later, again, you had this persistent headache, neck pain, and slowing. Child was started on methylprednisolone and anti-edema measures. A whole body PET-CT was done. Hypermetabolic lesions were mentioned in the brain, which they had suggested was likely infectious with no other hypermetabolic lesions elsewhere in the body. So child was still being treated for seronegative autoimmune encephalitis, possibly secondary to the orthobunia virus. And then a follow-up scan was done. On the follow-up scan, there were some new changes on diffusion sequences, again in the basal ganglia, the coronary data out there, and the posterior fossa structures. There was some degree of progression in terms of the changes. You have these the deep brain nuclear changes slightly more in comparison to the first study. You have the subinstar changes also were slightly more, and the posterior fossa findings also were still present with the temporal lobe abnormalities. The new findings on this scan was the anterior cingulate cortex region had these changes. Vascular study was not significant. The child, I think we had discussed previously, we thought of possibility of multifocal glioma, maybe a PML kind of a lesion or a CNS HLH, but we thought we'll go ahead with the biopsy. Biopsy was done on the left temporal lobe. It was sent to 2 centers. I think it has come out as inconclusive. for any abnormality. And the child was again rescanned today, post biopsy. Post biopsy, again, you can appreciate changes are there, but now they're slightly more prominent on the thalamus on the right side, more prominent on the right temporal lobe, and also the posterior fossa. You can see the middle cerebral peduncles, the pons. It is slightly more, and in the inferior cerebral peduncles around the peridentate regions, and also now going on and involving the cerebral tonsils. So in terms of imaging wise, there is interval progression starting from May onwards, and also from the previous scan, which was done 2 weeks back. This is post biopsy done today. Again, some new changes on diffusion, especially on the left aspect of the posterior fossa, and the left plix and the globus pallidus out there. No contrast enhancement in the supratentorial abnormalities, or no new changes. These patchy abnormalities were seen in the previous scan. Only this new area of patchy enhancement was seen on this present study. So this is just in comparison. This is the initial scans in May, and now you can see in August, there is interval progression in terms of the changes in the supra and infratemporal brain. The main question here is, what is the next step we need to do? Are we still thinking in terms of neoplasm or any other chronic inflammatory processes? Any other questions, Harika, regarding the next step for?
Yes, so like we have ruled out like infectious, para-infectious, and brain biopsy was also not conclusive. So one history what mother gave is they have gone to a forest like before May.
Okay.
So after that, mother also had headache for almost 10 to 15 days. She was taking medications almost daily, but whether it is
Let's think it is inflammatory or post-infectious.
yes.
If we assume that it is, there's no improvement on medication for almost 3 months now. And now it looks slightly more massy out here, especially in the temporal lobes. So yeah, thinking what is the next step if the group has any other possibilities.
I think progressing over such a long period, it looks more and more like a malignancy than anything else with so much of mass effect.
Yeah, I agree, Dr. Rakesh.
Yeah, I think we need to do an open biopsy. A stereotactic biopsy was tried, and there's a significant edema, and then they couldn't get the proper tissue. So I think we'll have to do open craniotomy and biopsy and some decompression maybe. Sure. Thank you.
The HTK27, okay. I mean, predominantly brainstem, but these also have supratentorial involvement. So I wouldn't say HTK27, but I would say, yeah, malignance glioma is one of the possibilities. She either says Trablaxine on PML, but child is not improving. So yeah, we thought as PML as one of the possibilities. Dr. Rani says, yeah, biopsy is mandatory. So I think we'll go ahead with the biopsy now. Given that you can appreciate the interval progression and not responsive to medication. So hopefully we get a good sample, and we'll come back to you with a follow-up diagnosis if we have a conclusive biopsy report. Balamurgan, can it be chronic EBV? But it's not improving. That's the main point. EBV, CMV should have been improved, should have shown some improvement. Yeah, Ata agrees with biopsy. Yeah, malignant same biopsy. Yeah. All right. Yeah, that should be our last case. And acanthamoeba, yeah, all the para-infectious processes considered, tested to be negative. Even if we didn't have the organism, the child was given appropriate medication and has not improved. So that is, I think, one of the pointers against the infective para-infective ones. Acanthamoeba, no, again, there would be some hemorrhages, some enhancement, some focal enhancing lesions, which is not seen yet. All right. I think there's no further comments. I think that's our last case, and we'll see you back on the 22nd of August. Kindly submit your cases by 20th, and yeah, if any previous cases have been discussed and have follow-up diagnosis, please let us know. It will be useful for learning. Thank you once again, and yeah, We'll see you on the 22nd.
Thank you very much.
Thanks again. Take care.
Thank you very much.
Bye-bye.
Thank you.
Thank you. Great. Thank you.